Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Excited to be sitting here today with one of the great healthcare critics of our time, Nate the Great, otherwise known as Nate Kaufman. Brilliant marketing with the N8, love it. Told you that last time. Nate is currently the managing director of Kaufman Strategic Advisors and Matterhorn Strategic Advisors. But I got to know Nate from his often critical and interesting content on the LinkedIns. And so I wanted to reach out and have a little conversation around your experiences in healthcare and specifically value-based care and your thoughts around it. So Nate, thank you so much for joining us today.
Thank you, Mendel. First, I'm not a critic, I'm a realist. I've been in this business 47 years. I spend 30% of my time as a executive in residence in a health system. I literally I'm down in the trenches with doctors and PAs and others trying to figure out how to deliver imaging and orthopedic care better and survive in this new environment. And so as a result of that, I have a very realistic perspective on where healthcare is.
Maybe before we get into the general concepts of value-based care, let's fast forward to some of very recent news. Walmart Health is all the buzz right now, just shut down 51 clinics and is out of the retail health market. There's a bunch of other large players that are shutting down, virtual health initiatives, telehealth initiatives. There seems to be a lot of big name, big powerful players that seem to be retreating very quickly from healthcare. What is your opinion on what is going on under the hood of these companies?
So there's a great saying: if you torture numbers long enough, they will confess to anything. And what's happening in healthcare is that there are these heroic assumptions being made that sound good, but unless you've been in the business a long time and you've been through the cycles, you don't realize that they're a bunch of nonsense. The people that are making these heroic assumptions they call themselves advisors. I call them salesmen. And as a result, people are being sold on false assumptions. About 20 years ago, we were going to buy a cardiology group at Piedmont Hospital. It's now called Piedmont Heart Institute, a fine organization. And Charlie, who was the CEO physician of one of the cardiology groups, I went up to him and I said, Charlie, if we buy your group, we're going to lose $40,000 a doctor. And he said to me, Nate, how much do you lose employing a nurse? And that changed my whole attitude about the whole business. You see, doctors are just part of the workforce that exists within the healthcare industry. They're not necessarily a separate profit and loss statement, profit and loss entity. And as a result, when you try to make money directly off of doctors and the doctor business, as they did in Envision, as they're trying to do in other hospital-based specialties like anesthesia, it doesn't work long term. And so what happened in Walmart and what's happening with Village and others is they're trying to make money off of primary care doctors. And there's no money there after you pay overhead and you pay their salaries. And so they've been sold.
Yeah, that seems to be kind of a common thing that I'm hearing. A bunch of people that are doing primary care for real, and there's a false perception that it's easy and you can create super efficiencies and make money. And it seems that the answer is that you can't. So is healthcare just not a business? Is healthcare losing proposition? Is healthcare just a societal charity that we all have to, get people to donate hospitals, and otherwise there's no way for it to float? What's the take?
Well, I hate the healthcare industry from the standpoint of the economics are just wrong. But we have to live within the economics because healthcare is a business. What a business is if your expenses are greater than your revenues, you disappear, right? And in healthcare, the fundamental problem is that Medicare and Medicaid pay somewhere between 65 and 85 cents per dollar of care. Even MedPAC has admitted that that's true with respect to hospital services for not-for-profits. So Medicare has also given physicians an 11% increase over the last 2 decades, while office expenses are up 40 to 60%, which has, by the way, driven all the physicians out of independent practice, mostly to the security of health systems, unfortunately. So as a result of the underfunding of the federal government and the migration of physicians to seek financial security at health systems, what happens is health systems, in order to survive in this business, has to find a funding source. And there's only one, and that is the employers. And so we are forced to cost shift in order to make the business equation work. I don't like it. It's not my favorite thing. It's the rules of the game. And if you want to survive in this game, every health system that is successful in part because of their rates.
So you're saying that the employer payers are floating healthcare, not the government?
That's correct. What's happened is healthcare providers are now are basically in the taxing business. So see, if Medicare acknowledges that hospital rates are too low, they have to raise payroll taxes. If they acknowledge that the outpatient reimbursement is too low, they have to raise premiums to people over 65. They're better off making believe that's not happening. And so as a result, they have forced people who want to provide great care and great access to have to tax the employer for the underfunding of Medicare and Medicaid. They did a study in Connecticut. The state published the study. The average Medicare patient reimburses a hospital 77 cents per dollar of care. And the average Medicaid patient reimburses a hospital 65 cents per dollar of care.
And the dollar that you're referring to is the employer paid dollar.
No, that's the dollar that the hospital. So if the hospital buys an
you're saying loss, total loss.
Medicare patient. Wow. Right. So if you accepted Medicare and Medicaid rates, you essentially would have a margin of minus 30. Wow. So what do you do? Now, I can't make excuses for the inefficiencies and the dysfunctionality that exists in health systems. Okay. We need to do better. Okay. But the fundamental problem is underfunding by the feds.
So, to my brain, not an industry expert, nor do I pose to be, but if that were the case, that the employers are really the ones that are paying for healthcare, the employers are also the ones that suffer, then a lot of the healthcare, I'm trying to formulate this question, a lot of the healthcare system basically suffers tremendously because of overregulation and because of the rates that CMS puts. They'll start a program and the rates will be very high and they'll get a bunch of doctors hooked on it. The next thing you know, the rates go away. It just happened last year through tons of, massive companies for a loop with when they came out with the new calculation for reimbursement rates around, Medicare Advantage or whatever it was that they did last year. So this happens very often, right? A lot of the problems are from the government side. So if it were the employers that are really floating healthcare, why don't they just break away into a totally separate system that can be more efficient, that doesn't have to be overregulated, because it's a simple consumer capitalistic market, that there's employers that want to pay for care and they'll find the doctors and they'll find the systems, and let it just be a simple capitalistic trade-off instead of this overly convoluted, overly regulated system that we find ourselves in.
Well, the problem basically is that the system is so complex, and the critical mass you need to deliver a healthcare system requires hundreds of thousands of people. I mean, you can see rural hospitals going out of business left and right. And by the way, the reason the rural hospitals are going out of business is because the payers aren't paying them fairly. We can get into that if you want. But the other piece that's happening is when you look at the employers, they're not only paying for 24/7 coverage, doctors that come in at 2 a.m. in the morning, administrators that have to meet huge, ridiculous regulations and staff their hospital and be ready to take any and all comers that come in the door. But they're paying probably somewhere between 20 and 30% of the premium to people that process their claims. And in fact, a recent study was done, it's on my LinkedIn page, where they compared the United States to other countries. And they said, we're about 60% higher, our healthcare costs. And about a third of that cost that's higher is a result of private insurance. I mean, the cost of conforming and getting paid by private insurance and dealing with denials is huge. It's huge. It's on average, a doctor spends 14 hours a week just on prior authorization. And then another third of the cost of us being higher is a function of our regulations. And so those are the two primary drivers of our higher costs, according to this recent study.
Interesting. Okay, so now let's tie it back into value-based care, because it's obviously the habits around
You froze.
The possible your perception of value-based care and its success or otherwise. So let's start with what are your opinions on the model?
Okay, so I don't have strong opinions about value-based care other than it's a scam. Okay. So it was a good idea, and it just went bad. I mean, I've been around long enough. I watched the idea coming. I thought it was an interesting idea. But here's the story. Value is a function of outcomes per unit cost. So the issue is we can't measure outcomes right now, right? So
why not?
Let me give you an example.
Okay.
This is from 2021. This is a quote from the Cleveland Clinic. We found that 28% of our second opinion consults result in a diagnosis change, while treatment plans are modified 72% of the patient cases we review. Think about that for a second. Almost a third of the diagnoses that they see on second opinion are wrong. Now, the question becomes, when you get an MRI, as an example, is the issue price? Can you get it for $500 or $1,000? Or is the issue how accurate is the diagnosis? I'd rather get an accurate diagnosis from an MRI procedure for $1,000 or $2,000 than get an incorrect diagnosis for $500. Now take that up to cancer, right? Okay. Getting the wrong cancer diagnosis and the wrong treatment. Can you imagine what the cost is for something like that? So the idea of value-based care should be that we're paying for the best for the most accurate diagnosis and the best state-of-the-art treatment plan per dollar. But no health plan is measuring that at this point in time. Walmart's doing some work in that area, but no health plan is doing that. What they're measuring is, are their patients getting colonoscopies? Are they getting mammograms? And in fact, what we find is that for cancer patients, less Medicare Advantage cancer patients go to cancer institutes than the standard Medicare patients like me, which is why I would never go into Medicare Advantage. I'll stop ranting.
So, but I still don't understand how value-based care is not, in fact, the answer to your problem. It would seem to me that if the original doctor, well, let's take the flip side. Fee-for-service creates the environment that that Dr. A that maybe had the wrong diagnosis, right? That doctor is not incentivized to really, really make sure that diagnosis is correct because they're in fee-for-service. So what's the worst-case scenario? Patient comes back, they get the right one. Maybe it takes 2-3 times, whatever. It is part of the system, right? But if I was Dr. A and I really assumed risk on this specific patient's outcome, then it would be in my best interest to make sure and have the correct systems in place to really ensure that I'm creating the right diagnoses. No.
Well, here's some bizarre fun facts. Okay, so in Medicare, let's use Medicare and Medicare Advantage. In Medicare, the challenge is errors of commission, that you do too much.
Okay.
In Medicare Advantage, the incentive is errors of omission. Thus, you hear about AI analysis rejecting, authorizations and so on and so forth. Personally, I would rather have errors of commission than errors of omission. If you make a big mistake on me, but I may not come back if you're not providing the treatment as quickly as I need it. And when you talk to doctors and here's the other problem, and I'll name the institution, Scripps. They've been capitated for decades. They had 35,000 capitated lives. They lost $75 million on those lives. They determined the reason was culturally, doctors couldn't work in two worlds. Yes, if you're Kaiser and everything is Kaiser and you do it the Kaiser way and it's a closed system, yes, you can take risk. But the idea that 2/3 of your patients will be fee for service and a third will be risk, they found culturally it just doesn't work. And they say, what, culture eats strategy for breakfast? So, the question is, so that's another challenge. I mean, it's not like, oh, doc, if we just put you at risk, you'll figure it out. The other problem is, who's measuring the outcomes? Who's determining whether that doctor used the right, diagnosed the patient correctly and treated the patient correctly? I mean, we don't have those tools. What we're using is what I call the knucklehead CMS quality indicators. Did the patient die within 30 days? Were they re-hospitalized within 30 days? Nothing about did that patient get, let me give you one other example. The Society for Thoracic Surgery has a star system for determining the outcomes and quality of cardiac surgical programs. You want to go to a 3-star system program, right? Do you think the payers pay a 3-star system more than a 1-star system? Even though they're measuring outcomes, they get better results, they're doing all the things they should be doing? Absolutely not. So this whole idea of that we're doing value-based care, it just isn't happening. It's built on a rickety platform of fraudulent risk scores, of PBM ripoffs, and other things. And as I think now, because of United being investigated, we'll see more people digging into all of this stuff.
But you would agree with me that when you bring it down to a small example, right, and you take out all the convolution of the massive system, it does seem to make sense. Or I'll give you an example. I have a friend, his name is David. He's maybe 60 years old, and he started a practice, mortgaged his house, found money somehow to buy a practice, turned it full risk, bought a bunch of other ones, and he ended up selling the portfolio after a couple years for stupid amounts of money. And it's a really cool story on its own. But the most interesting part was that he told me that at one point he had a doctor that he was paying, I don't know, $350,000 salary, and the doctor's entire patient panel was 7 patients. And he said, because he was able to do the math and look at the data, and he determined that those 7 patients were costing him $2 million in utilization. And so, it made sense for him to just take one doctor and pay them $200,000 to $350,000 and say, you manage the crap out of these 7 patients, make sure they never have a need in the world, never step foot in the ER. And that was worth it for him. And that kind of math seems to be the good value-based care. That seems to make a lot of sense.
So let's talk about 2 issues. The first issue is, having gone through the cycle in the 80s and 90s where Medicare Advantage practices were, doctors like David were getting rich. Where did the money come from? It didn't come from their salary, those doctors' salaries. came from avoiding hospitalizations. There was an institutional risk pool, and at the end of the year, they didn't use all the money, and so the doctors got that money. A hospital would be foolish in today's environment to do that kind of contract. Why? Because most good hospitals are full. Why would you want to not get your fair share of the Medicare dollar and let somebody else get it? Right?
Okay.
So that's number one. Number two, Medicare Advantage. I got three then. Medicare Advantage, because of their denials, delays, and downcoding, are paying hospitals 80 to 90% of the effective Medicare rate. I am begging hospitals to only accept contracts where they get paid, and if there's a for all claims, and if there's a denial, there's a clawback. So that doesn't impact their cash flow, and that they're assured of getting a yield of at least Medicare from the contract. So the days of having a slush fund from the institution, I think those days are numbered, if not over. The second thing is we rely on primary care. There aren't any primary care doctors out there. 80 in a local university, there were 80 internal medicine residents. One went into office-based primary care. Everybody else went to subspecialty or hospitalists, right? So finding a primary care physician is going to be unbelievably difficult in the future. And this whole idea that the answer is primary care, we didn't fill the pediatric residency. The internal medicine doctors are not going into primary care. I think the average primary care physician stays in primary care like for less than 10 years because it's a burnout. And so for all those reasons, we have to get over this idea that primary care is the answer, because until we pay them fairly, which is like $400 or $500 as opposed to $200 to $300 like the other doctors, you'd be nuts to go into primary care unless you're just totally altruistic.
Would you say that a lot of the primary care physician's role has been kind of segmented into various different new, specialties, because there's been a lot of new knowledge and a lot of new data, and it's simply impossible. Like, it used to be that the family physician was a family physician. They did everything. They were the pediatrician. They were everything, right? But since there's so much more knowledge and research in medicine, you simply cannot know everything anymore. And that's why there's all these new kind of specialties. Does that make sense to you?
Yeah, but that's not the reason there aren't. But again, if you haven't noticed, I always go back to facts. So here are the facts. The fact is that for a primary care physician to survive, they have to see somewhere between 20 and 30 patients a day. Okay?
To survive under what system?
Under any system.
Meaning, who's paying them?
Well, the typical primary care physician, 60% of their patients are going to be Medicare, which is the whole problem.
Right.
At the end of the day, they're going to make $250,000, $300,000 a year if they're lucky. If they're an independent practice, they're worrying about cybersecurity. They're worrying about prior authorizations. They're worrying about all kinds of things. Retaining their medical assistants, who are asking for bigger and bigger salaries. Never mind a nurse. So at the end of the day, primary care is a noble profession, but as it stands now, it's a horrible business. When I talk to primary care physicians about their business, what they say to me is they go home at night wondering what they missed. And why do they wonder? Because they have to see so many patients in order to just survive. So if I've gone to medical school, why am I going to go into that business when I can go into rheumatology, I can go into GI, I can go into surgical specialties where I can own ancillaries like surgery centers and actually make money from patients that I refer, if you will, without having to see them as much. Right. So, I don't know.
So let's go back to drivers of cost. What is, because you seem to be very well researched. In your opinion, what are the key drivers of cost in U.S. healthcare?
Okay, the key drivers of cost in healthcare are 10% of the patients. That's what most people don't understand. 10%, 1 out of 10 patients, consumes 80% of the healthcare dollars. Okay, 50% of the patients of the people in our country use less than $500 of healthcare per year. Less than 500. This whole idea of price transparency is the stupidest idea I've ever heard. Because with the 10% that consumes 83% of our healthcare dollar, they're in the system. They've got cancer. They've got multiple chronic conditions. They're under the care of physicians. They're not going to be shopping, wondering whether they can get an MRI cheaper down the street than in the hospital. They're just hoping that they can survive another couple years.
Okay.
And so that's the first step and the problem in our healthcare system is we haven't organized care for these people. So for example, if I was talking to a woman the other day, her sister has leukemia. Do we have a leukemia center where once you have leukemia, you go into this center and now all your care is provided by a group of physicians and specialists, and we have home health leukemia specialists and so on and so forth? No, it's a fend for yourself healthcare system. That person may be seeing 3 or 4 different doctors. They may or may not be communicating with each other, and it's a big mess. And so if we wanted to reduce the cost of healthcare, 2 things. We need to organize care better. But the second thing we need to do, and this is a very simple thing, we need to standardize what insurance companies do. Cigna has a way of doing things. Aetna has a way of doing things. United has a way of doing things. And each of those are different. If you read their contracts, which I do, what it says is we can make administrative changes unilaterally. And they all do. They make these, use this form, use that form, send this patient here. If everybody did it the same way, the business office costs would go down to almost nothing. The second piece is if there was an independent body that could determine medical necessity, rather than United does it their way, Aetna does it their way, and so on, then it would be a whole lot easier to be able to standardize or know how to deliver care in this country. Right now, it's total chaos. So simplify administration, and then providers need to organize around disease populations. Like my mother's 97 years old. She should be in a frail elderly program. She isn't. She goes to her eye doctor. She goes to her primary care doctor. She goes, to different places. That's what she does. We're going to try to get her to stop driving. So somebody takes her there. But anyhow, that's another story.
I don't know why big companies use insurances. What's the role of the insurance payer to a company that has enough employees to pay? Mark Cuban, by the way, he actually said it on this podcast. He's doing this now. I think he announced it on this podcast. He as soon as his contract is up, he's dropping his insurance providers and he's self-contracting with the systems.
So
I don't know why that's not common practice. Like an insurance should be looked at as like, if you're a small company and you can't afford an accountant, so you outsource that. And then once you're big enough, you just hire the accountant, right? Like just hire the person to manage healthcare at the company.
So insurance companies are aggregators. They aggregate all of the providers in a market. And actually, in many cases, for large companies like that have multiple locations around the country, they aggregate the drug providers, the home health providers, and so on and so forth. That's what they do. And then they process all the claims. They take care of all the paperwork. They provide a useful administrative function. The problem is they're being paid way too much for that.
It's a simple math equation, though. At a certain point, the amount that you're paying them is a lot more than just hiring the 3 people to do all that. Like you got one person doing claims, you got one person doing the aggregate, or even if it's 50 people, whatever. There's got to be a math equation number that just says, okay, now we've passed the point that this is worth it. But for some reason, no one seems to do that.
Well, I think what Walmart did was very clever. Lisa Wood, who I was on the podium with her about 2, 3 years ago. She went around the country, went into the places and said, I want a center of excellence for cancer. She measured whether, in fact, whether they were measuring quality by and outcomes by doctor. She measured whether they were doing team planning, and she provided a bundled rate that was plus or minus 15% what they would have gotten under fee for service. In some cases, it was more. Why? Because if you get a better diagnosis and treatment, it'll cost less in the long run. And the idea is you send your spines to, this hospital, you send your transplants to Mayo and so on and so forth. That idea makes a whole lot of sense. Again, keep in mind, our problem is not with 75% of the population. Our problem is with 25% of the population that has multiple chronic conditions. And so the idea of centers of excellence is a good place to start.
So you want to see the system move in a direction where you basically, the care that somebody receives revolves around their state of illness or chronic condition rather than the patient revolving around the system. You want to see the system revolve around the patient demographic, at least. Obviously not the specific patient. We're not each going to have our own system. But if I fit into bracket A, I should be seen by system A. If I fit into bracket B, I should be seen by system B. That's number one. Number two, you want to see, you're right. It's funny. Congress, didn't Congress pass, I don't know if it was Congress, but I feel like Congress passed the bill to force Apple to change their charger from the Apple charger to the standard charger, so that because everyone in Congress has a cell phone and they got annoyed with switching chargers, But yet with healthcare systems, each health system has to contend with multiple different processes and.
Well, they approach things differently. And so that's one of the challenges. It gets to the concept of population health. People talk about population health to keep people healthy. I think that's another nonsense concept, not because I don't like the idea, but because I haven't found research to support the cost benefit. My example is if a health system who has limited resources, we're trying to recruit nurses and ICU nurses and doctors, and we're going to go out and spend $5 million and do smoking cessation programs. And lo and behold, there's less smoking in our community because of it. And as a result of that, there's less lung cancer in our community. Who benefits from that? It's the payer. The payer benefits.
Why?
Because they don't have to pay for it, right?
Right. Premiums don't go down. Yeah.
Right. So it should be the payer that takes care of the wellness piece, right?
Right.
Or pays the provider to take time out of their day, taking care of all the sick patients to do the wellness piece.
Yeah.
The evidence is that when you tell people to eat well and to exercise and do that, they don't do it anyway. It's a waste of time. So for me, my argument is healthcare providers are in this, people say the sick care business. I call it the intervention business. We do mammograms really well, colonoscopies really well, ICU really well, and so on. So EDs sort of well. And so on. So that's where we should put our resources. And then my definition of population health is identify populations with common clinical characteristics and build subsystems for them.
There's a really interesting system in South Africa that I've heard of multiple times from people that were there for a couple of years. And I'd love to explore it more with someone from there on the podcast at some point. But it seems to be, it's a private system that you buy insurance from. And first of all, from what I was understanding, the whole experience is really cool. Like, it's a cool experience. Like the person that was describing it to me described it as it feels like you're walking into an Apple store. When you're like, there's super helpful, fun, fit people that are there explaining the various different plans to you. And the idea is that you get a plan and then because you get a plan and then based on your wellness, your premiums go down and down and down and down and down. So if you do go to the gym, if you do keep the diet, it will literally go down. Similar to the most driving insurances, right? Geico has an app. They want you to download it. They'll give you a discount, and then it monitors your driving. And if you're driving well, you're not such a risk. If you drive crazy, then you're high risk, right? So yeah, for some reason, the Medicare Advantage benefits, I haven't looked into this extensively. It sounds like you may have, maybe you have, but I feel like all those gym benefits and the sneaker benefits, and they probably don't go anywhere. But for some reason, it sounds like in South Africa, it is going well. And I'm really curious to know why. Maybe it's because they seem to be targeting it's not a senior thing. It's an everybody thing, and it's a young person thing, and maybe get those habits ingrained when you're 30, and when you're 60, you'll still have it. I don't know. Have you ever heard of that system?
No, I haven't, but I mean, I'm open to anything. I mean, I think it's a great idea if we could figure it out. The problem is there's 3 trillion websites that say if you eat fast food and drink sugar beverages and your BMI is high, you're going to probably get diabetes. And so the information's out there, and our diabetes rate and our child diabetes rate is going through the ceiling. So it's obviously not just having the information available that's going to make a difference.
Yeah. Well, again, the issue is we also have at every single one of those fast food companies, you have entire departments of scientists dedicated to addicting people to their food. So exactly. Between the book and the billboard usually wins, right? Definitely an interesting thought around the micro systems. I mean, but going back to your what you said about population health, isn't that the intent of population health management? Isn't the intent to look at the population and then cater to, all right, this population, we really want their A1Cs to come down. Let's talk to them about it. Let's figure out how to change their habits. Let's figure out what their social determinants of health are. Let's figure out what's causing it with this individual population. Isn't that the intent of population health management?
Yeah, but it's more education oriented. I'm in the delivery and intervention business, not in the education business, because I'm not getting paid to be an educator, number one. And number two, it doesn't seem to work. They've done studies on it. It doesn't seem to work. So if diabetes would be example. If somebody comes in diagnosed with diabetes, maybe I have something where I go out to an employer once a month and people have to come to a class and they are assigned a navigator and they have to come see our diabetes PAs this many times. And if this happens and that happens, and we have foot and ankle doctors that specialize diabetes. So in other words, a whole delivery model for diabetics. That's my business. That's where I think we can have an impact.
Well, that brings me back to kind of a central thing that I've been talking about for years, which is that at the end of the day, the biggest problem with the culture around healthcare is that it's the doctor's. My health is the doctor's problem. Especially if I have free healthcare or next to nothing, there's no consequence for me to be not healthy except the long term, even though I'm the one that has the most to lose because I'm the one that will die if I'm extremely unhealthy. But we as humans don't know how to look further than the burger in front of you typically. And so there's no immediate pain. There's no consequence. You have like the whole dynamic. I've said this so many times on this podcast, like the whole dynamic of like you said, like why does the education not work? Because the dynamic is, let's say chronic care management, right? The dynamic is me begging you, Nate, to sit down with me for 20 minutes a month and let's talk about your health, right? Like imagine if that was the dynamic with your financial advisor. Imagine your financial advisor was chasing you and saying, Nate, we got to sit down for 20 minutes and talk about your spending habits. And you're like, okay, maybe, okay, fine. And then the guy sits down with you, he gets paid like $60. And then he talks to you for 20 minutes about your spending. You're like, okay. And then you get up and you continue racking up debt on your credit card because what kind of dynamic is that? We got to figure out how to get the patient back at the center of the consequences of healthcare.
Well, as one of my heroes, Kurt Vonnegut, said, we are a crazy species. So again, the concept of what we should do and what we actually do are two different things. And I think we have to deal with reality, especially given our limited resources.
Yeah. Yep. Well, fascinating conversation. I've always envisioned, it's funny because you've said, I think, some really good things. I always envisioned, my thing was, all right, imagine a system where my drivers of cost are the overregulation of the healthcare industry, which leads to all the administrative burden, right? Which I could go into, but whatever. Second thing is malpractice insurance, because we love to sue our doctors so much. And the third thing is the pharmaceutical, companies' profit margins and the high cost of drugs, which aren't really, like, you look at what Mark Cuban is doing, they just don't cost that much. They don't, right? And so I envision a system where people signed off of HIPAA, basically. So you know what, the Russians can know I'm early stage diabetes. I don't like, at the end of the day, they hacked Change Healthcare. Did someone knock on someone's door and steal their liver or something? Like, what happened that was so catastrophic? That's first of all. Second of all, it's still a crime to steal someone's data. And yet, like, if I stole your private messages with your kids, that's still a crime. And yet you could pull out your phone and just WhatsApp them or text them. Like, it's not, you don't have to sign into 4 different portals and remember your password and get a text with a notification. Like, you don't have to do that, right? So sign off of HIPAA. Which takes away all the administrative burden. Now, all the systems can look like any other tech system. That's really good. Second is, adopt real value-based care. So give them, give this system actual, risk on the outset. And then thirdly is, go like Mark Cuban style with the pharmaceuticals. And,
let's talk about Mark Cuban style for a second. There was a study done by the Senate Committee on Health for New Mexico. They looked at prescription drug costs. They found that 23% of prescription drug cost copays exceeded the cost of the drugs that the PBMs bought them for. Okay? The middlemen in our healthcare industry, our healthcare industry is driven by greedonomics. Everybody's trying to make a profit, and everybody is trying to take more. And because 30% of the dollars now, because of the PBMs, are flowing through the insurance conglomerates, okay, that's the first place that we need to attack. Attacking hospitals and physicians will affect care and will affect access. It's already happening. We have care deserts out there because rural hospitals are closing because the insurance companies are unwilling to pay rural hospitals what they need to compensate for the underfunding of Medicare and Medicaid. And the rural hospitals don't have the negotiating clout to get paid more. So they close. So the issue is, where are you going? Rather than looking at it theoretically, let's look at it from the standpoint of what can we do? We need to go to the place that's making the most profit and providing the least value. And that's the PBMs and insurance companies. And we need to rationalize what they do and how much they get paid. That will save a bunch of money. We also need to put pressure on health systems to become more efficient and less dysfunctional. There's no excuse for that.
Well, there is an excuse because it's overly regulated. That's the problem. They can't do anything.
Well, it's overly regulated, but also working in tons of health systems as I do, there's all these bureaucratic silos. For example, the medical group reports up to the system office. The hospital reports up to the system office. So, and nobody's coordinating in the local region. How do we provide the best service? Deming said that if you try to optimize all the subsystems, you sub-optimize the system. And so if I have the budget for the medical group and my goal is I got to make the most money for the medical group and I have to make the most money for the hospital and I have to make the most money for the Heart Institute and so on, then the system is just not going to work. So we have to figure out, we have to balance the kind of national oversight and the regional oversight of health systems so that they can become more efficient, more responsive to local markets. But so, I mean, that's a tough job given their cultures at this point.
Yeah. Love it. Well, this has been, I feel like we can go on for hours, but this has been an intriguing conversation. I definitely appreciate you coming on and keep putting the facts out there.
Yeah, I hope you realize I'm not trying to be a critic. I'm trying to.
No. Hey, critic isn't, I don't see that as a negative word.
I'm just trying to correct people who, just one last thing I want to point out. There is an effort on the part of certain venture capital funds, special interests, who are now funding academic research against providers. it's unbelievable. I can't even believe what's going on. And the academic people have no clue. One academician, for example, said this: people should be given since cash prices are lower than negotiated rates at some hospitals, people should be given the option whether they get paid cash prices or the negotiated rate. Well, that is the dumbest thing I've ever heard from a PhD. Why? We create cash prices for people that don't have insurance, right? And by the way, there's no prior authorization. There's no major claim forms. There's nothing. They pay cash, right?
Right.
So
right.
the business office cost is lower. If there was a law that said that the cash price, that anybody could get either the lower of the cash price or the negotiated rate, what would hospitals do? They'd raise the cash price. And now all of the people that were getting the benefit of a lower cash price would suffer. But you get these venture funds paying academics money. Just one last point. There was one situation where a Yale study, it turns out it was disclosed that United Healthcare had edited the study published by Yale.
Wow.
So you have to be careful what you read and what you hear in our industry. Yeah. It's being tainted. Anyhow, I thank you for letting me rant for an hour.
And it's been a lot of fun. I know people can find you on LinkedIn, Nathan Kaufman, or just N8, and he'll come up, which again, brilliant. Anywhere else people can find you or should find you? Kaufmansa.com, KAUFMANSA, as in StephenAlbert.com, or also Matterhorn Strategic Advisors on the web. We do large investment banking projects, and our focus is on advising and not sales. Love it. Well, Nate, this was a lot of fun. Thanks so much for joining.
Thanks a lot, man. Have a good one.